Okay. So what we'll do is, yeah, we'll hopefully get a chance to upload this before the end of the week, but if not, early next week, and then we'll post the link on our socials. So yes, we're joined today by Ciara Breen and Ciara Wright. So Ciara Breen is an occupational therapist with an amazing knowledge of conditions like long COVID and ME, and runs the Bri Clinic. And Ciara Wright is functional medicine clinician and nutritionist of Positive Nutrition. So Ciara, both Ciaras have been with us before for Q&As and lots of amazing knowledge shared. So yeah, we just thought it would be useful to have a discussion around this topic. Couple of, I suppose, housekeeping things. Just in terms of the format, we wanted to keep this quite informal. So I was going to chat for a couple of minutes, share a little bit about my own experience, and then both the Ciaras will run through a few things. And then Jenny, we're joined, I think we should be joined by Jenny Cooney, who is a researcher in this whole area. So I think she was going to talk to us a little bit about her research for a few minutes. So yeah, if you want to ask a question or share an experience, you can either use the raise hand function in the reactions, or you can just pop it in the chat, whichever is easier. Sorry, I'm just going to change that 2 seconds so I can monitor that. Okay. Yeah, perfect. So yeah, we'll see how we do with time, but hopefully we should get through a number of questions. So let me just make sure oh yeah, I suppose to warn people that obviously anything we discuss today, people share, or Ciara Wright or Ciara Breen discuss, isn't medical advice. And if you're considering changing medications or trying HRT, or, worried about your hormones or anything like that, obviously always talk to your own doctor. Okay. So we've got the recording going. Right. So I suppose a little bit about my experience. I have had post-infectious ME for 13 years. And fairly soon into my ME journey, I realized that I had my PMS every month was getting a lot worse. And so eventually I was diagnosed with a condition called PMDD, which is premenstrual dysphoric disorder. So really what that means is it's kind of like a very severe version of PMS, where low mood, anxiety, and physical symptoms as well. And so for a lot of women, they can find that they're dealing with those kind of symptoms all the way through from ovulation to menstruation. So kind of half the month you're feeling like crap. So that was definitely an issue for me. And I'd also noticed, which I think a lot of women with ME and long COVID notice, is my symptoms of ME would be worse at certain times of the month. So the fatigue would be much worse, the brain fog. And I would say to anybody who's kind of wondering about PMS, if it's got worse since long COVID's developed, or that kind of thing, is to definitely look into PMDD, because it's, really tough to manage alone. I think diagnosis and management is really important. So that was that. And then quite early on, then a couple of years after I first developed my ME symptoms, I had my first ovarian cyst rupture. Ended up in hospital, and had many problems, many ovarian cysts, one requiring surgery, until eventually I got one of my ovaries out to see if that would solve the problem. And then was having chronic pelvic pain, got a diagnosis of endometriosis, again, multiple surgeries, and then eventually got a hysterectomy 2 years ago at age 39. And luckily that has left me pain-free. But I suppose, why I mention all of this is I don't feel it's a coincidence that I only developed these issues after I developed my ME symptoms. Never had any problems with my hormones before. And I think what we're seeing now, the emerging evidence, is that women with ME, long COVID, these kinds of illnesses have a greater incidence of gynecological issues. So yeah, I suppose that's because of that journey myself. It's an issue that's real close to my heart. And I know from chatting to women over the last few years, hundreds of women, experiencing similar. So that's why I thought it would be useful to get people together to discuss it. One person I did want to flag is a lady called Louise Newsom, who's a GP specialist in women's health in the UK. And she kind of did some interesting work around around long COVID over the last couple of years. And she was kind of explaining that really any virus can affect ovarian function. And with COVID, because the SARS virus binds to ACT receptors, and we have a lot of ACT receptors on our ovaries, that's why we're maybe seeing a particular problem with hormones following COVID infection. So yeah, that's a little bit about my journey. I hand over to you, Ciara, if you about your observations around this.
Thanks a million, Sarah. Yeah, it's really interesting. And I am a clinician. As you mentioned there, I'm an occupational therapist, and I work a lot with people with long COVID. But also with people presenting with fatigue, across a range of different conditions.
Oh, I think we've
And
lost.
so very often, it's sometimes can be unpicking, the different. Sorry, Sarah seems to have frozen actually, so perhaps it might be her line. I hope not, but yeah. So sometimes it can be picking apart. What might be long COVID, what might be an underlying coexisting condition, or sometimes even an evolving picture like menopause. Where we know that people are most likely to be diagnosed with long COVID are women aged between 40 and 54. So very much that perimenopausal and menopausal journey being a very common thing that people are managing alongside long COVID symptoms as well. So really interesting actually, Sarah, that you'd mentioned there about Louise Newsom, because I know she talks a lot about menopause in her work as well. And I think just that, if we like, that natural change that occurs in midlife, but which can create some significant challenges when you're managing it alongside another condition. Um, and then I myself have endometriosis actually, so very familiar with endometriosis. And of course, again, we know that people with endometriosis are actually at a higher risk of long COVID. So, it's actually, it's not surprising that there is overrepresentation, of people with endometriosis conditions like that, in than our long COVID population, because there's more likelihood of them having long COVID from a COVID infection. And I suppose there's a lot of shared characteristics. So as a clinician, again, I suppose my emphasis is really taking the whole picture, and kind of going, okay, as we unweave, the threads and unweave the fabric of this, do we need to unravel them all, or do we need to kind of really see what the pattern is as a whole? We're more than the sum of all our conditions. And I suppose it's really looking at what that looks like for somebody day to day in terms of pacing. And then also looking at what that looks like over maybe the course of perhaps a menstrual cycle. So do symptoms change over the course of that menstrual cycle, for example, in terms of then that awareness of, gosh, even being aware that your hormones might influence your fatigue levels, your pain levels, your blood volume, for example, in somebody who has that more kind of POTS sort of subtype as well. So just that awareness means that people can then begin to implement strategies and anticipate, because I think sometimes when it comes to sort of my job, which is about function, I think anticipating and being able to understand what tomorrow might bring, or what next week might bring, gives power back to the person with long COVID to begin to be able to put in a strategy that might support better function. It might be increasing your electrolytes in the second half of your cycle. It might be around adjusting maybe your work pattern. It might be around social kind of engagements or those sorts of things, so that you're sort of planning and responding to where the demand might better match, for example, your energy levels. And then I have some people who actually function better in the second half of their cycle, and that's because progesterone can sometimes make us a little bit more sleepy, and a little bit more sort of, downregulated, a little bit more likely to maybe find better sleep. So maybe sometimes things like insomnia improve during that second half. So while in theory, maybe fatigue is going up because they're getting much better sleep, perhaps in that second half of the cycle, they can feel better. They can feel more able. So I think that's why it's really important. It's not a one size fits all, but it's really listening to the story, uncovering the pattern, and then maybe trying to come in and respond to that with some strategies that just support function. So that's my sort of overall approach to it. What about yourself, Ciara? I might hand across to you now.
Thanks, Ciara. Yeah, that's interesting. So I feel like our jobs are very complementary actually, because what I'm trying to do is find out a little bit more about even like the levels of people's hormones and then what they could be impacting. And everybody is very different. And I think that we all kind of assume when we're going into the perimenopause and the menopause that the estrogen is dropping, that's what's causing all the problems. But actually, a lot of the time it isn't, and it really depends on the person. So in the perimenopause, what you can actually have is quite high levels of estrogen. And if you already have maybe, it's probably one of the reasons, well, it is definitely one of the reasons why more women get long COVID, but it also can be procoagulatory. So that can be an issue in long COVID. There's also probably an infectious relationship between not being able to fight off bacteria related to endometriosis. Like there's loads of reasons why that makes perfect sense that women with maybe higher levels of estrogen through their life are much more likely to get long COVID and endometriosis and all of those things. So I will be looking at people's different levels. Sorry, that's what I was saying. So higher levels often than we expect in the perimenopause. And what's actually happening is that a lot of people aren't ovulating very successfully, or not at all in some cycles in their perimenopause journey. So what you have there is lower progesterone versus a higher estrogen. And you don't even have to have, and this is the problem probably with blood tests, high estrogen or low progesterone. It could just be higher and lower. And one of the problems is that the HSE loves to measure your estrogen on day 2 and loves to measure your progesterone on day 21. And those two things are very far apart in a cycle. We should really be measuring both of them on the day 21 or 7 days before your cycle and seeing what kind of imbalances are there. And vice versa, you can have patients who have great progesterone, really, really high progesterone, and then for whatever reason, their estrogen isn't great. And then they get all the symptoms of the menopause, and yet they still have estrogen. They'd still be in the normal range of estrogen, but it's the balance between those two. And I do have a kind of an interest in the knock-on effects of that, really, in terms of things that happen in your brain. And as Ciara just mentioned, progesterone is your calming hormone, even though it doesn't feel like that, and it's not always works perfectly in PMDD, obviously. But it's the kind of brakes on your brain, and it does help you sleep better. Whereas estrogen can be more excitatory. It can drive histamine, which is a massive player in chronic illness and long COVID. And that's also a major vicious cycle because they just both like feed off each other. And then you can get things like high glutamate excitotoxicity, which was great when we were younger and healthier because it gave us extra focus. You know, when our estrogen was high, you found you were able to work harder or whatever it was, be more creative. Whereas when you're already chronically ill or going into the perimenopause, menopause, that's now way too much. And it's really overstimulatory, and it can increase sound sensitivity, light sensitivity, all of that kind of overwhelm, and, too much where you need to go down and lie down in a dark room. So the balance between those two things I find really important, and how they're potentially driving on inflammation in the body, and how you're going to try and get in at that system, because everybody's levers are slightly different. And for some people, it's trying to, I use like kind of a tap and a bucket like a plug analogy, like less insulin, signaling to your testosterone, you're like turning off that signal at the top, or do you need greater detoxification, get those hormones out of you? What kind of balance do you need if you were going to go to a HRT specialist? Because they are a little, I mean, some of them are great, but it is a bit of one size fits all when you go in first, right? They go, try this, come back and see how that goes. But if you have a little bit of data, or you can put together the patterns for yourself in terms of what phases cause what problems, then you can kind of go in an idea of, I'd actually do better with some progesterone, or I'd actually do better with much more estrogen, or reducing my estrogen, whatever it might be. So yeah, I do like getting into the kind of nitty gritty details of it all.
Thanks so much, Ciara. Yeah, it's really interesting. I suppose it is so different, right? It's fascinating to me that there are people out there who feel better, in the second half of their cycle. So I think, and it occurred to me, I suppose, that the women that have the regular cycles, that's kind of the gift, because then you can kind of plan, if okay, around the 20th of the month, I'm going to feel like crap this month or whatever. But if they're not regular, it's quite difficult to plan for resting beforehand, resting after, knowing, that week that your energy will be less. So yeah, that's really, really interesting. Thank you both so much. We might go to Jenny if Jenny is still on the call. Do we have Jenny?
Yeah, hi. Hi everyone. Oh, can you hear me?
Yeah, we can hear you.
Yeah.
Lovely to meet you. Thank you so much. Did you want to tell us a little bit about your research?
I'd love to, thanks. Sorry, I'm a bit red. I think probably like most people here, I'm suffering with the heat.
Really, yeah, it's unbelievable. I think we're all on the same boat.
Yeah. So hi everyone. I am Jenny Cooney Kwan. I'm a women's health researcher in UCC. And I just want to thank Long COVID Advocacy Ireland for letting me have a few minutes just to talk about some research that I'm doing that's related to long COVID, especially in women. So the research that I'm looking at is looking at healthcare interactions. So instances of symptom dismissal, minimization, misdiagnosis, I guess kind of commonly known as medical gaslighting, as well as positive healthcare interactions. The conditions that I'm looking at are conditions that disproportionately affect women. So I'm looking at a range of conditions, and conditions today as well as long COVID. So things like long COVID, obviously, PCOS or PMOS, PMDD. But what I'm also looking at is around the use of symptom tracking apps and wearables. So things like pain trackers, period trackers, and also heart rate trackers, like to track their symptoms, to, I guess, get a better understanding of what's going on. And, as Ciara was saying there earlier about, teasing out which symptoms are related to which health conditions, or, when there's overlaps. And also using that data to kind of evidence to their doctors, like, look, I have these things going on. Can we investigate? Could it be long COVID? Could it be other things as well that are being driven by long COVID? So what we're looking at in our current, so first of all, so we did a survey at the end of last year where we kind of asked, I guess, kind of short answer questions around these topics. But what we're doing now is a more in-depth study where we're carrying out interviews. So we really want to hear kind of more in-depth what women's experiences are tracking all of these symptoms. So long COVID symptoms, other health condition symptoms, as well as alongside their menstrual cycle and potentially, into perimenopause and across post-menopause as well. So we're really interested in, what that experience is tracking those symptoms. Like, is it really burdensome? Especially when, you're dealing with a lot of fatigue, be it physical or cognitive fatigue. Is it really insightful for yourself? Do you learn to understand or get a better understanding of what's going on in your body, and also what your experiences are when you bring that, that tracked data to the doctor? Are they really interested management of the conditions, or again, is it kind of something that's dismissed that doctors don't have time for, or they're just not interested in? So yeah, so basically the interview will kind of be exploring those different aspects of tracking symptoms across a wide range of health conditions. And very quickly, don't worry, I'll stop now. I won't go on for much longer. So in terms of eligibility for the study, you need to be female or assigned female at birth, to have at least two health conditions, at least two health conditions, to have been tracking your symptoms in some way, so using apps or wearables or both, especially alongside your menstrual cycle. And yes, sorry, those are the things. My brain is a bit gone now with the heat.
No,
But
fantastic. Well, it's really interesting, and I think a lot of women will definitely feel that, that reflects their experience with maybe trying to get the doctor to pay attention. I think maybe both to their long COVID in general, but then also to maybe their perimenopause symptoms or whatever issues they might feel, are going on. So yeah, thank you so much. It actually reminds me of we're helping support a study in Toronto. It's happening at the moment, called the episodic disability wearable study, and basically it's using the episodic disability questionnaire that was developed for long COVID, and a kind of an 8-week tracking of it's kind of a small sample size because it's very intensive, and kind of trying to connect, I suppose, the feedback from the questionnaire in terms of symptoms flaring with the wearable data. So I think it'd be really interesting to kind of see the output from that. But yeah, thank you so much, Jenny. I really appreciate it.
thanks,
It'd
Ash.
be good to find out how that's going. Okay, so we might take some questions then. And yeah, as I said, if you want to unmute, and ask your question yourself, just raise your hand. Otherwise, you can pop it in the chat, whichever is easier. I just see one there right away. So from Leah, how do we measure hormones? My understanding, what doctors keep telling me, is that there's no real reliable measure due to fluctuations. I've been repeatedly prescribed hormones via the pill, HRT, but no one has ever actually checked what the hormone levels are. And I might put that to you, Ciara W. But just on that, I think that's one of the things that Louise Newsom was flagging. I'm not sure if you would agree, Ciara, is that she was saying, well, we have no diagnostic test yet for long COVID, and we have no diagnostic test that's reliable for perimenopause, menopause. We have this hormone test, which really is, a lot of people don't feel is like super, helpful. I mean, it's kind of better than nothing. So, how do we actually find out what people's levels are?
Yeah, I think probably they're referring to things like FSH, which is your follicle stimulatory hormone, which is a message from your brain that goes to your ovaries when it's like putting your foot on the accelerator going, you're not doing enough. Would you please make more hormones? And that is the one that fluctuates. And it does go up post-menopausally because your ovaries are not making any more hormones really. So the FSH goes high. So everybody thinks that, the doctors might think that that's the test we're kind of asking for. And if your FSH is going up, that means you're headed towards the perimenopause, but it doesn't, right? It's not great. It absolutely can fluctuate. And if anything is causing your ovaries to be quieter that month, etc., then your FSH could go up that month. And actually, that it just reminds me of something when you were saying before that you didn't have hormone problems until after you got ME. I mean, is that like there's a bit of a chicken and egg situation? Was it the stress on your body from having ME? It's a little bit like, elite marathoners who don't get periods, or if you're working really hard, you might skip a period month, but your ovaries just go, oh no, the stress hormone basically turns off that whole pathway. So that FSH could go up and down for any other reason, for stress, for illness, for lots of different reasons. So that marker is not a good marker of perimenopause. So I'd agree with her there, doesn't. However, the idea of gatekeeping, sorry, I'm just going to get like annoyed now. The idea of gatekeeping, like measuring someone's estradiol and progesterone, is outrageous. It's outrageous. It is not an expensive test. There's an idea that you wouldn't benefit maybe from, I don't know what the aim of it is. Like if they're saying that, well, if your estrogen comes back normal, you could still try HRT. That is true. Because like I said, it's all about the balance, and some people operate better at higher levels. Some people operate at better lower levels. So it shouldn't guide maybe it doesn't guide their prescribing. I don't know why they don't want to run it. But for me, I've had so many women who think that but and like I said, because there's so many overlap symptoms between the perimenopause or the menopause and all sorts of chronic illness. I mean, arguably chronic illness is worse, right, than your average perimenopause symptom. But there's so much overlap. How do you know how much of your aches and pains and fatigue is just coming from your hormones, or is it coming from the rest of your condition as well? So lots of women thinking, oh, I must have low estrogen, that's the problem. And then they get their estrogen level, I'm sure it's miles high and it's not the problem. And it could be the progesterone that's the issue and the lack of ovulation. Now, granted, that can change month by month, but you can also get things like, at-home progesterone tests or sticks or whatever, if you wanted to track it on a serial couple of months to see if you are in fact ovulating, like 3-4 months in a row. You could do all of that. There's options out there. This idea that, oh, don't bother, it's useless, I just think that's really lazy. And if they do think they're fluctuations, they're not a very expensive test for the HSC to run, like as far as budgetary issues go. Measure them twice, measure them 3 times, measure them in 3 cycles in a row, and get a picture of what's going on. If you have estrogen low on 2 cycles in a row, maybe you have low estrogen. I do really love getting an estrogen measured on day 21, but that's also a push because the guidance says to measure FSH, LH, estrogen, all those on day 2. And then the only one you care about in your luteal phase is progesterone. But it's obviously not the case, especially if you're getting more symptoms in your luteal phase. You should be trying to. So it is very tricky. Obviously, there's private ways of getting it done. And there are loads of really interesting private tests, but they obviously cost money.
Of course, yeah. Thanks so much. Yeah, I know. I think I spoke to multiple women now who've actually been refused HRT, and the doctors said, "Oh, well, you're too young to be in perimenopause," which is just kind of I find astounding, because obviously some people can be in perimenopause for a long, long time, and I suppose the range of age, right, is huge. So, yeah. I suppose why wouldn't you be allowed to try it if you feel like it's worth it? So definitely, I know people have had that issue with their doctor. And then I think we have the other side, where I think some women on the call might feel that, like, there's been times when doctors have put their long COVID symptoms down to, I think I saw a post today to say, if you're a woman under 40, all your symptoms are anxiety. And if you're a woman over 40, all your symptoms are menopause or perimenopause. So I guess it goes either way, right? Most definitely. Sorry, there's a question here. Just what's the exact name of the test to ask for, Ciara, when requesting a hormone check?
So an estradiol or a progesterone. Like I said, they'll probably be thinking you need an FSH, but I don't even think that's that useful. I think it's your estradiol and your progesterone. I mean, by all means, if they'll do your testosterone and your DHEA as well, if they're willing to do those, that would be great. Your testosterone doesn't fluctuate that much throughout your cycle. You can get it done any day. I do think that's valuable as well. It plays an important role in your energy and your mood and all sorts of different things. And even things like, which people experience for various reasons, like hair loss and skin issues and immune issues and all sorts of things, but very rarely measured in women as well.
Yeah, absolutely. Someone's asking there, does anyone know of long COVID patients having more problems with HRT than non-long COVID patients? So this, like, I feel like this is a really maybe common worry for people, because I know a lot of women with these kinds of conditions maybe have a history of not tolerating the contraceptive pill. I tried so many different pills, couldn't tolerate any of them. And a friend of mine who'd long COVID said, look, it's still worth trying HRT. And I was really glad I did. I was quite surprised. That said, I did have to start really slowly, and there definitely were side effects. So would you see that kind of sensitivity to the HRT more so than other women?
Yeah, but I suppose you might have been taking that pill on a different kind of settings. You might have been 18, 20, 25, had, underlying issues of other description that you didn't even know about going on. And now if you're taking HRT at a later stage, you might genuinely have lower estrogen. I will like to say there that you don't only need to take hormone replacement therapy for perimenopause. I mean, what is the definition? That is the before menopause natural reason why your estrogen might be going lower. But like I said before, it could be stress, it could be lots of different reasons. If you measure low on estrogen, it's like thyroid hormone replacement. You're just replacing something that's meant to be there. So back when you took the pill, you might have been putting hormones in on top of other hormones. Whereas if you measure low in estrogen, and you absolutely go low dose for sure. And also then there's more like bioidentical ones, which tend to react better to, and all sorts of things. So if you're replacing something that you're missing, it tends to go better than if we were just chucking hormones in at a different problem when we were a bit younger. But absolutely, I mean, is there any way to tell what a long COVID patient is going to react to? There absolutely isn't. And there is that idea that, so estrogen can be pro-inflammatory, right? It's good for your immune system in one way, but if you're already in a raging state of inflammation, is taking more estrogen going to be a problem? Possibly. It's pro-coagulatory. If you're already in a coagulation cascade and you took extra estrogen, is that going to be a problem? Possibly. So there is all sorts of risks. And I think the only thing, which is what we do with everything, right? Every supplement, every medication, everything, try it on its own. So you don't, there's not too many things that are interacting there. As in like a new intervention. Try the lowest dose you can possibly get out of the tube or whatever. And just go really, really slowly and take breaks if you need to.
Yeah, absolutely. Yeah, that's really interesting. So I didn't know, like, if say there's a woman in her 20s, early 30s, where kind of menopause is definitely not on her radar, you would still say you shouldn't assume your hormone levels, your estrogen, your progesterone are fine. It is okay to ask for them to be checked.
Yes, absolutely. Yeah, that's
wow.
Crazy. And I mean, I will say, when you were younger, and again, it depends on if your cycle is regular and all of a sudden your hormones drop because of stress or illness or whatever, more than likely you're going to notice that in your cycle when you're 25. There's going to be some kind of change, spotting, change in duration, length, missing days, late, early, whatever shape or form. And these are the pieces of information that you need to bring to your GP and talk about logically, as in like, well, I used to have a 20, and a lot of them be like, oh, well, it's just changing, it's fine. But these are the signs and symptoms of changing hormone levels. So why wouldn't you check? But there's lots of different reasons why you can have lower estrogen, and finding those reasons out is really important. Yeah, I definitely think so. Yeah.
That kind of leads me on to a related question, which is, I suppose, for those women who maybe have tried HRT and don't tolerate it, or only tolerate it, maybe only able to take a very small dose before they're triggering a lot of maybe flare, or for other maybe reasons, maybe clot risk or that kind of thing, can't take HRT. Is there any other method of managing those kind of perimenopause symptoms?
Yes, I mean, and that's where I think, first of all, there's things like phytoestrogens, which you can get in supplements and foods. Now, they are not as strong as real life estrogen, right? But I mean, in terms of protecting our brain health a little bit and our heart health and all of those kind of things, they are a great thing to have in your diet. And some people will find the supplemental forms quite useful for certain different types of symptoms and aches and pains and etc. So they definitely have their place. So they act on some of the beneficial estrogen receptors, not as strong as real estrogen, but they will impact those pathways. But for me, I think it's again looking at, but what is going on inflammation wise? Can we change that? Right. So totally, we can't take the hormones because of, say, clot risk or whatever. So is there anything we can do to protect our brain from the changes in excitotoxicity or neuroinflammation? And that's the kind of part that I'm quite interested in. It's not easy, right? I mean, if we could solve neuroinflammation with a supplement, sure, I'd be a millionaire. But those are the kind of levers that you're then trying to pull. You're like, okay, well, I don't have estrogen, but what was it that it was acting on that now I can try and modulate those pathways instead?
Sure. Harriet, do you want to see your hand there?
Yeah, can I just jump in on what Ciara's just saying there? I think one hormone that is less often thought about in terms of replacement for women is testosterone. And particularly estrogen, that can exaggerate the reduction in testosterone. And if we're thinking about, well, if you go on estrogen at HRT, then you are losing testosterone quicker. And part of the benefit of testosterone, although the research is pretty sketchy, or in the early phases, but it does seem anti-inflammatory, mast cell stabilizing, and it can improve bone mineral density with or without estrogen. So there's still loads of benefits. And a lot of the symptoms we get with long COVID mimic symptoms of low testosterone in men. And if men had had those symptoms, they would be getting testosterone, but because we're women, we don't. And numerically, women produce more testosterone than they do estrogen throughout the entire cycle, although not all of it's active. But numerically, we produce a lot of testosterone, a lot more than I think a lot of people think. So I think there's a lot of benefits. I know some of my clinical colleagues in the long COVID, muscle activation, ME space, when they come to hormone replacement during menopause, they tend to flip it round and they'll start with testosterone, then think about progesterone, and then go to estrogen as the last resort because the first two are more immune stabilizing. So I think there are ways to manipulate hormones and not forget testosterone in the process is just my 2 cents.
Yeah, and that's really interesting you bring that up because actually I remember speaking to a woman with ME who had very similar issues to me in PMDD, and she definitely found, the HRT helpful, sorry, the traditional estrogen progesterone, but when she added testosterone, really had huge benefits. And in Ireland, anyhow, it's not licensed, and the GPs generally won't prescribe it unless you've issues with your libido. That's the only thing they'll prescribe it for, which kind of seems, typical, typical.
Yeah, and that's frustrating because obviously if you're chronically ill, libido is generally the last thing on your mind, but it's also very heteronormative. So like I'm asexual, I don't have a libido. So I will never be able to get testosterone based on the licensed use, which I think is very discriminatory.
100%. Yeah, it's extremely frustrating. And I know, the blood tests they'll do, like you said, Ciara, I suppose it's a little bit more reliable than maybe it's a little more steady throughout the month, but they were very much, unless it's officially, we're seeing it kind of reduced. And obviously I know they need to take care with these things, but it does seem to be extremely guarded, women's access to testosterone. So that's, thank you so much, Ari. That's really, really useful. There's a couple of other questions that came up. Just around, this one for you, Ciara.
Just I might come in on the lifestyle piece around menopause as well, because
Yes,
I think
please.
actually one of the big things around somebody's saying, what else can we do around menopause? And I think one of the big messages that is happening around menopause and that space at the moment is around and Harriet referred to it as bone density, those sorts of, things around I should be strengthening, I should be doing X, Y, and Z, because otherwise my later life is going to be, forecasting kind of maybe bone fractures or premature, difficulties in terms of mobility and those sorts of things. So that I definitely see as a conversation that comes up a lot because there's so much messaging around that at the moment. And I think it's just really important to counter that in some ways with the overall picture, and it's really thinking about, for me, I think a lot of the conversation is not just can we throw hormones at the wall, and see what sticks. But actually, do we have an underpinning theory as to how this will help? So, as Harriet was saying, do we have an underpinning theory as to how this is going to support bone density? Ciara was saying, do we have an underpinning theory around how this supports or doesn't support maybe an inflammatory cascade? Those sorts of things around coagulation. And I think probably where the real challenges, be they lifestyle issues or be they medication, be they hormones, it is kind of where there isn't a kind of a plan. It's kind of just test it and see. If it works, it works. And definitely I see that, of course, as an occupational therapist with sort of some of my maybe more rehab colleagues kind of going, well, try the strength program and if it works, it works. But actually we know that sustaining, and we've spoken many times about post-exertion malaise and the impact of that. But I just want to mention it because it's something that comes up so often on calls, is that women are feeling really guilty and bad and worried about their their bone health in particular, I think, and their skeletal health in terms of not being able to exercise. But it's so important that actually people understand that the inflammatory cascade that follows things like post-exertional malaise, the functional impact of post-exertional malaise, meaning that you have a net lower baseline and are doing much less overall, I think is really, really important to consider as well. So just wanted to throw that in there.
Thanks so much. Sorry.
Bored to tears with my no more prescribing.
No, not at all. My internet seems to be being affected by the recording. So if that isn't correct, I'll have to stop recording. Thank you so much. No, that makes a lot of sense. So a bit of a more detailed question here. Someone with immediate menopause, following AstraZeneca vaccine. So on greatly diminished bone density post-COVID, how can one manage weight-bearing exercises while pacing?
I think we missed the end of the question.
Sorry.
Sorry.
How can one manage weight-bearing exercises while pacing?